Good to have you all aboard. My name's John Summers, and I'm the unflattering name of Infertilityman, but it's all part of our story. So Laura and I met 2017, and I guess when you're a little older, you know, well, I guess what you want. So we sort of, the discussion about fertility and babies started pretty early in our arrangement or relationship. And I found a doctor, unbeknownst to her. I found a doctor on online, actually, just sort of, that's for me. Anyway, that doctor, we actually started a cycle with Laura, and with my history as well with the testicular cancer. We sort of went in with the idea that we were going to have to do the MicroTESE, but they found with a fine needle aspiration, we only found one sperm, and we thought, right, if we've got the MicroTESE and Laura's cycle goes, and I don't think we're the only ones that think it's going to work first go, but we were quite innocent and naive at that time. Even with my one sperm, we thought, well, they should find what they need in with the MicroTESE. Laura's first cycle didn't go to plan. They went for the first checkup to have a look at the follicles, and there were nowhere near as many and as they thought, and that actually ended up being cancelled, which led us on another journey to find another fertility specialist who actually recommended Dr. Katz. And that's how we ended up with Dr. Katz. I ended up doing 2 MicroTESEs. My Laura had to do 15 egg retrievals before we were able to transfer and have our young lady. So that's our short story, although it took a few years. So Dr. Katz, this is why we're here tonight. He kindly offered, he's not really one for social media, and he's kindly offered to spread the word with regards to male infertility. He is he should join us sometime soon. Let me just have a look here. As he's coming on board, I think I've done the right thing. We will. Hey, Dr. Katz.
Hey, John. How are you?
Yeah, I'm great. I'm just giving you a quick intro. Urologist, specialising in male fertility and microsurgery. You're the medical director in Men's Health Melbourne, and yeah, you were trained locally and overseas as well in New York. Is that right?
Yeah, that's right, John. As urologists, we sort of train in everything when we finish. One thing we don't get trained in, well, virtually not at all, is infertility. And when I finished my training, I realized that this was a need back here in Australia. And just like you, when I looked online, I said, well, who is the best people in the world in infertility, in male infertility, that is? And the team out at Cornell, New York Presbyterian in New York, upper east side of Manhattan, Dr. Peter Schlegel, who invented the MicroTESE, Professor Goldstein, who does lots of reconstructions, vasectomy reversals. I said, that's who I want to go and learn with. And so off to New York I went and spent quite a long time. In fact, all up, I spent both research and clinical about 2 years in New York. And I came back to try and basically help Australian men with their infertility, men like you, John. And, you know,
yes, very grateful indeed.
Correct. So, you know, I'm grateful that I was given that opportunity by those mentors, and I still keep in contact with them with difficult cases, but I'm very happy to, you know, bring those skills back here to Australia and to raise sort of male infertility to the next level.
Yeah, that's fantastic. It's fantastic. Now, Dr. Darren, I know, or Dr. Katz, I know this may not be appropriate, but I know you haven't met our daughter yet, but she is ready. She is ready to just pass out. So if you don't mind, just a quick
that'd be awesome.
Hello.
That will be awesome. Oh, wow.
Who's Dr. Katz? She
is absolutely stunning.
Yeah.
Hello.
So this is why we did it all. So we really appreciate what you did for us.
That's very good.
Yeah.
So what you need to do for me, Jon, is
yes.
you've got to send me a photo. I call all of these children my babies. Let me quickly show you what I mean. All right, Jon, I'll quickly show you. This is
here, baby. I'm put it to sleep.
Here are my walls of all my babies.
All right. All right.
And this, continues on this wall here. And Jon, I really want you to send her to my, my highlight wall, please.
We will come in. We've got to get in and see you and actually have a photo with you. So I think that we'll arrange that very soon. Quick, fast. She's growing too quickly.
Yes, especially such a beautiful baby like that. I would love that for my wall. Thank you. Yes.
Yes. All right. So sorry, people. We digress. Dr. Katz, we put out a week or so ago that we were going to have a chat, and on the groups that we're involved with in the infertility man through that the social media there's a lot of people that end up asking about this MicroTESE procedure, which I ended up having twice, which I know when we went into it, we weren't aware that it was possible to have it a second time. So are you able to, in your term, well, I guess try and make it as layman's terms as possible, the MicroTESE procedure? Can you explain that to us?
Sure. Look, no problem, Jon. So a MicroTESE is done for patients who have got no sperm in their ejaculate. Okay, so even though when a man ejaculates, they can see fluid coming out. In fact, sperm only makes up around 1 or 2% of the actual volume of the ejaculate. So even though some men see their fluid come out, their semen come out, if it doesn't contain sperm, it doesn't look any different. And I'm sure you can attest to that, Jon. When you were ejaculating, you didn't see any difference at all. You didn't notice that there was any difference.
Well, it is funny now. We know why. I know this is not something like I never ever had a pregnancy scare. We now know why that happened all those years before I was lucky enough to meet Laura. I was worried for nothing.
What can happen though, it takes a lot of sperm to be made in the testicle just to get one out into the ejaculate. Okay, it takes a lot. But in men who don't have any sperm in the ejaculate, what we do know is that sometimes somewhere within the testicle there can be what we call a needle in the haystack. One little bit of the testicle that can still be, or one or maybe sometimes a little bit more, bit of a testicle that can still be making sperm. And what a MicroTESE does is under very high power operating microscope, I operate on the testicle, I look at all parts of the testicle, and I try and find that needle in a haystack, that one little bit that looks like it might be making sperm. What we do then is I take out that little bit of that testicle. It's a tiny little, less than a millimeter bit of the testicle.
Right.
Inside the operating theatre, there are usually 1 or 2 embryologists present in that operating theatre. I give them that bit of that testicle. They then look under an even higher power microscope. Sometimes it's a benchtop microscope, probably up to 400 times power, and they're looking to see if that little bit in fact has sperm. Okay, to confirm my suspicions. And what a MicroTESE does is I go through all parts of the testicle, Jon, and I basically look at, I get what's called live feedback. So at the end of the operation, I've looked at all parts of the testicle to know whether or not sperm is present. Now, if we happen to strike it lucky and hit the jackpot early, then we stop. Okay, so if I open up and I see a good area and I think it's favourable for making sperm, and the embryologist says, yes, we've got stuff here, we've got enough for the eggs and we can freeze a bit more, then we stop. So we do that on one testicle, and if we don't find on one testicle, we go to the other testicle. And that operation, although it sounds quite involved, it is only day case surgery. It can take a few hours to do, actually. And it's quite labour intensive. You're looking down a microscope for several hours. So for me, you know, generally I only do one on a day because, you know, you need to really concentrate. I know, as you can appreciate, John, this you've really just got one shot in most men. You were lucky you had two, but most men got one shot at it. And so you really want to make the first shot the best shot. And that's basically what a MicroTESE is. Yeah.
Right. Well, I know for me, I was surprised when I woke and found out that I could do it again. It sort of actually changed our whole plans again, because we were actually ready to use that sperm to put with the eggs that Laura had, and we were going to go down that road. But the fact that we had another MicroTESE in the bag was like, well, we have to put more eggs away to do that, so that I can sort out my hormones. But anyway,
correct.
We can come back to that later. So question 2 that we had a few questions come in from the followers. Is it worth doing a MicroTESE a second time? So we found that out if no sperm was found in the first surgery.
Okay, so it's a good question. Essentially, it depends on who's done the MicroTESE. There are different people do MicroTESEs differently. I do the way that I was trained in the United States, and I am confident that when I do a MicroTESE, if I don't find sperm, then I'm confident that there is no sperm in that person's testicles. When I operate, I'm operating at, like I said, using a very high power microscope. In fact, there are only 2 of these that I know of that I work at in Melbourne. Other people might use lower power microscope, different microscopes. Anyway, so I don't want to comment on other people, but I know what I do. And so your question is, have I found sperm when other people have done biopsies or MicroTESEs? Yes. The answer to and have not found. The answer to the question is yes, I have. So it is possible, but it is much, 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 much more difficult. When you operate on a testicle, it's a very fragile organ. It scars very easily. And even if someone's done just what we call even just a limited biopsy, you can cause scar tissue. And when I'm trying to find that needle in a haystack, instead of finding it amongst nice sort of soft tissue, when you're trying to find that amongst concrete, which is scar tissue, it becomes very, very difficult. So essentially what I tell all my patients is your first shot should be your best shot, really. And most of my patients, the vast majority who come to me will have a MicroTESE, not a little biopsy, not anything else, if I know that the problem is that they're not making sperm.
I think I recall when we were speaking the first time, you actually told us to bypass the different biopsies with view to that fact that you mentioned scarring can create an issue if we were to find something in a MicroTESE in the future. So we went straight to the MicroTESE and sort of booked down the line. Now, so just a quick one and add on to that that question. So, have you heard of there being a maximum number for the MicroTESEs, or can you sort of go until?
No. So John, look, you were the exception, not the rule. Most men only have this once. As you know, with you, I sort of did find that area that was favourable for making sperm very early on, and so I didn't have to dissect or look at an operator on all of your testicles. So that I knew that somewhere else in the testicle there were bits that were untouched. Right. And so when you wanted to go for more, I knew that I was confident of finding. Now that's not common. Usually there's not that many places. Sometimes there's only one. I remember one time a few years ago there was a patient who. It was into the 3rd hour that I found sperm for this man.
Right.
But this is what it's about. I mean, John, this is you and Laura, it's a huge journey you've gone through, right? It's sometimes years in the making. And firstly, not only has it been years trying, and then it's, all the egg retrievals, all the hormonal changes, all the prescriptions, all these things for both of you. It's an emotional, physical, journey. And it's all come down to the MicroTESE. So I know how much you guys have invested in this journey, this process. So it's up to me to invest as much time, as much energy that I have to try and give you the best outcomes. So, you know, I don't stop until I'm confident that I've looked everywhere, really. Yeah.
All right. Well, that's great. Again, very appreciative. And here we go. Question number 3. Thank you for answering that one. Is there a limit on the number of, now this is a bit different, needle aspirations that a man can have? So I know I had one of these and they did 3 passes where they found one motile sperm. What are your thoughts on this?
So as I mentioned before, John, look, I don't think needle aspirations are that worthwhile for lots of reasons. Needle aspirations in themselves are basically blind passes of a long, sharp needle into your testicle. That can cause damage and scar tissue in its own right. And so it can make the potential MicroTESE more difficult. It's less trauma than a biopsy. And so what I mean by patients in terms of the scale of operating on a testicle, you can put a needle under local anesthetic into a man's testicle. It's very blind. You sort of just poke around and that's what you do. And so that can cause some damage. You probably remember that not so fondly. I didn't do it, as you know, but then there is something where somebody can just do what we call a random biopsy of the testicle, and those are the ones that I really don't like because they can cause lots of damage and scar tissue. That's when they actually take you to operating theatre and take a bit of the testicle out. And then there's a MicroTESE, as I described beforehand. So I don't think fine needle aspirate is useful in the majority of cases, especially if it causes trauma and makes it more difficult for me the next time. That's my opinion.
Okay, and just a quick one. There's a quick question that's popped up here. If sperm was found in the MicroTESE, is it worthwhile doing a fine needle to try and have fresh sperm on the day of egg collection?
Okay, so let's talk about this as a process. So in my practice, and John, this is what we do with you, I use fresh sperm routinely. Okay, so how does that work? How do we use fresh sperm? And that's because the partner's eggs are collected well in advance. They're frozen. They're kept in the freezer. What happens is then the patient undergoes the MicroTESE. If we find sperm, those eggs are then defrosted, they're thawed out and injected. Any excess sperm is frozen for another round. But so I always use fresh sperm. What I say always, the vast majority of the cases are done with frozen eggs and fresh sperm. So that in my practice, I don't really use frozen sperm.
Yeah. Okay. Okay, great. Hopefully that answers your question. The next one. So can teaser help for high DNA fragmentation? So maybe even just give a quick rundown on DNA fragmentation as well.
Yeah, so DNA fragmentation, all sperm has got some degree of DNA fragmentation. All sperm does. And in fact, as it passes through the parts of the testicle and through the penis, etc., it actually, the sperm DNA fragmentation, not individual sperm, but overall, it actually decreases. And what we do know, though, and this is actually some new guidelines that have come out of America just this year, that if a patient has, this is not someone like you, John, but someone who actually has sperm seen in their ejaculate, and they do an assessment and the DNA fragmentation is very high, then taking sperm out the testicle can result in better outcomes.
Okay. Makes sense.
But every man has got some degree of DNA fragmentation.
Yeah. Okay. And is that related? Can that be related to, let's say, diet, lifestyle as well, or as well as sporting things?
Yeah. Like so DNA fragmentation is relatively new. We're still learning a little bit about it, and there are different things that can that can cause high DNA fragmentations. One thing that I do look for, which has been well proven, is something called a varicocele, which we can talk about now or another time. But a varicocele in a patient can cause high DNA fragmentation, and removing that varicocele can lower the DNA fragmentation and improve actual ICSI outcomes. And that's a whole other area that we can talk about, but it's very interesting. And certainly we know that patients who have got less, who have got, let's say more health issues, smokers, those type of things, do have problems with DNA fragmentation as well. And we think patients who take some multivitamins. So if a patient has a poor DNA fragmentation, we think some multivitamins may be useful to do in those certain circumstances.
All right. Well, good. I know DNA fragmentation. It wasn't something we actually looked into. It was more so the fact we were just looking for sperm, anything that moved. And even after that, fine needle, and it was immotile as well. So I can remember Laura and I just being annoyed that the actual clinic we were in didn't actually keep that. And we're like, hang on, that could be John's only sperm. So after what you've said about fine needles too, we were very lucky to get that one, which actually led us down the road to find yourself. Otherwise, we would have been looking down the donor route.
But that's that's really an important point to make for your followers, John. What you don't want is for them to say, well, we'll just do a little fine needle, we'll see what's in there, or do a little biopsy and we'll see what's in there. You don't want that, because what happens if they did, happen to hit the lucky shot just by chance, right? And that was the only sperm that was in your testicle. Yeah, that's a problem. That's a real problem.
Well, that would have been my journey to me having my own child. That would have been it for me, and then we would have been looking for a donor. So I'm not sure whether you can see this question that's popped up here. If they've got a small number of immotile sperm, which is like what I had actually, in the ejaculate, is it likely to find motile sperm via the MicroTESE?
More likely it is. Well, so the question is, if you've got a small number in the ejaculate, is it more likely to find sperm in the testicle? The answer is yes. Okay. Yeah. There is a condition called virtual azoospermia, cryptozoospermia, where sometimes there's a bit of sperm in the ejaculate, sometimes not. Yeah. Most of those patients have sperm. And yes, it would be, they might not be motile as the sense that you might see in ejaculate, i.e. moving forward, but we'll be hoping that we might see some what we call twitches or twitching sperm that move a little bit, and those are the ones which we try and inject.
Okay. I hope that answers that question there. I think that gives a good rundown. Now we're talking with, if I pronounce this right, varicoceles. Do you suggest surgery in the case of a varicocele, obviously around the testes, I would imagine? Correct.
So let's just first define what a varicocele is. Now, look, I mean, I'll preface that by saying this. We can talk for 2 hours just on varicoceles alone. But a varicocele, I bet I won't. but a varicocele is essentially varicose veins in the testicle, sitting above the testicle. So you've got your testicle down here, you've got the varicose veins sitting on top. And and it's quite common actually, 15% of men actually have a varicocele. So it's very common, and most of the time it doesn't cause any issues. In some men that it does, okay? And one of the issues it can cause is problems with the sperm. And as I mentioned, it can cause problems with DNA fragmentation. There are different theories as to why that happens. One theory is a question that I often ask patients is, why do you think, John, your testicles hang outside the body? Okay, people look at me a bit funny, and that's a bit of an odd question. But the reason why the testicles hang outside the body, John, and you'll find that they lower when it's hot and they're close to the body when it's cool, is because the optimal temperature to make sperm is about 2 to 3 degrees below core body temperature. So that's why when it's hot, your testicles are lower, and when it's cold, your testicles are a bit closer to the body, to try and maintain that balance of 2 to 3 degrees just below body temperature. That's why they hang outside the body. Now, what a varicocele does, varicoceles carry the blood from the testicle back into the body. And if those are too big or cause a problem, there's too much heat going on all the time, right? So your testicles can't get that optimal temperature to make sperm. That's one theory. Another theory is it releases something called free radicals, which can cause problems again with the DNA, et cetera, et cetera. So these are all theories that people have looked into. But ultimately it comes down, these are all academic things. Ultimately it comes down to, you look at a patient, you look at the size of the varicocele, okay, because little ones I think have got, what I believe are less important. Big ones are more important. The size of the testicle, often you can see a bit of a shrinkage on that size. You look at what's called the semen analysis. So there's certain patterns that you look out for as to whether or not this is significant. You look at that DNA fragmentation, all those type of things. And if you tick certain boxes and you're having problems with conceiving, 100%. I've taken out varicoceles in men who are deemed to be infertile, and they've had children. You've improved their semen count, and that is a well-known pathway that's been shown in numerous studies that patients who have low sperm count, you remove a varicocele, it can increase the sperm count. Now, what is less well known, and which is what I try and lecture my IVF colleagues on, is that varicoceles can actually cause problems with IVF then itself. Okay, so sometimes I've removed varicoceles in patients who are going through the IVF journey to help them with IVF. Okay, and that's not well known. And a lot of people think that the sperm only is there just to basically go into the egg and start to make an embryo. But in fact, we know that the quality of the sperm makes a difference all the way through pregnancy, even through the first, second, and even up to the third trimester, but definitely up to the first trimester. So there's a really good study with thousands of patients, looked at patients who are having early term miscarriage. Okay, and some of these patients had normal sperm counts with varicoceles, and what they found is if you took away the varicoceles, those patients actually had more live babies, less miscarriages. So the man's varicocele was a factor in why these couples were having early to recurrent miscarriages. So it's a very important point, actually, the varicocele.
Okay. So the main thing it does is it improves circulation around that area. It
improves the environment for the sperm to be made. Okay, so the testicle is a fragile organ. Okay, different things can cause it to not function as well. And if you have an environment where there's lots of heat or these varicoceles for whatever reason, then the sperm aren't made as well. And sperm are very fragile. For instance, if a patient comes into me and they've got a poor sperm count, I'll ask them, tell me, were you unwell in the lead up to this? If you've got the flu or, if you've been unwell, it will affect your sperm count. Sperm take around about 2 to 3 months, let's say 3 months, to go from a little cell into a mature sperm. And if over that journey you've been unwell, it's going to affect your sperm count. So that's important to appreciate.
Okay, well, thank you for such a comprehensive rundown. I think you might be able to see this one. So we've had a few hearts on this one. What about sperm antibodies?
Okay, so it depends in what context we're talking about. Sperm antibodies are often made by the body for different reasons. It can be a cause of infertility. Generally, if you have a high degree of sperm antibodies and patients are failing to conceive naturally, then IVF is a very good solution to that problem. People talk about giving steroids and things like that to try and overcome sperm antibodies. The literature and the science behind that is poor. The side effect profile is high. And if a patient comes to me with a high level of sperm antibodies, which are sperm attached with a little antibodies, we're not going to go into that, but little antibodies attached to the sperm, and they're infertile, I direct them to an IVF specialist.
All right. All right. Well, Joe, hopefully that covers your question. The next one on the list. So this is regarding supplements and vitamins and male infertility and male fertility. In your experience, would these help improve the chances for a male going through infertility or on a journey?
So it's another great question. My belief is every little bit counts. Okay, and who knows what that little extra 1% does. And so when patients say to me, Doc, can I do this? Can I do that? I think that if you're going to maintain a healthy lifestyle, take a good multivitamin, and there's different ones on the market. In fact, I just saw a new one, something called Ball Boost. I've looked into the reason why, because it was brought to my attention. It's a new one made in Australia. I'm looking into that. That looks pretty good as well. Something called Menovet's another one. Very common ones. I think it's worthwhile looking into these multivitamins, because there is some data to support its use with showing improvement in sperm parameters. But one thing I do want to say, and this is really important, I come in, if a patient comes into my clinic and I fill in some of the medications they're taking, and you see a whole lot of lists of, everything possible from this naturopath, from that Chinese medicine doctor. They've taken the Ball Boost, they've taken the Menovet. I just want to do everything. Actually, I tell them to rationalize it. Just take one. Okay, because there is some data out there that says that you take too much, it can actually be detrimental. People don't appreciate that. You do need the right environment. The sort of analogy that I use is, if you think of the sperm as a little seed, if you think of the cell that makes a sperm as a little seed, and you want it to germinate, you want it to come into a nice plant, you need the soil to be just right for that seed to sprout. Now, if you decide, right, I'm going to put this fertilizer on, that fertilizer, or I'm going to put this nutrient, now let's just put all these nutrients on, it's probably not going to be good for the soil to have too many nutrients, right? It's just going to be the right balance. And that's exactly what I say for patients coming with a whole host of supplements. Let's just try rationalize them, just take the Ball Boost or something like that, just take the Menovet, and we can go from there.
Yeah, and I know in my case you only had me on one, and that was for my case, and there was research around that actually helping the potential quality of the sperm if we found any. So yeah,
correct.
Yeah.
So I can see Laura's asked what medications should a man take in the lead up to a MicroTESE. So essentially, I do recommend a multivitamin. But a patient does need to be assessed, like you were, John, for hormonal imbalance.
Yes.
It's really important to look at that, because there are some hormones that need to be corrected to try and, again, improve that environment so that sperm can potentially be made. The problem, though, is that a lot of patients there are basically two functions for the testicle. Function number one is to make sperm. Function number two is to make testosterone. And they often go hand in hand. Low sperm, low testosterone. And so people try and do the right thing, and they say, I better find some testosterone, boost it up. And in fact, if someone takes testosterone, that is the worst thing that they can do. Taking testosterone actually kills sperm. You know that, John. That happened to you. It actually kills sperm. And it's not well known. In fact, surprisingly, there's a study that came out of America. This was a long time ago, but they asked some American urologists, if a patient came, they were infertile and they had low testosterone, what would you do? And 25% of them were going to prescribe testosterone. So even amongst urologists, at least in America, it's not that well known, but it's the worst thing. So a lot of patients who have been taking testosterone for a long time, most of them are infertile.
Yeah, right. Yeah, right. God, I know for me, I was put on that because my testosterone was low, and we finally found out that no sperm.
Correct.
Well, that's another reason why.
If you recall, John, I think we needed to sort of put you on a whole lot of other medications to try and write everything.
Yes.
That's a really important part of the workup and the process before you reach MicroTESE.
I know my follicle stimulating and luteinizing, everything was just working so hard to try and correct what was going inside my body, and I had to just come off everything for a period of time before we could actually see what my baseline actually was. That was that was an interesting journey. So that's supplements and vitamins. Are there any pre-operation tests that might help inform whether or not it's worth doing the operation, the MicroTESE?
100%. So basically, you need to have your hormones sorted out, okay, and genetic tests. Those are the two key components. But essentially, there's only one or two genetic conditions for which there's essentially 0% chance of finding sperm. And these are rare. And unfortunately, once or twice a year, I do have to tell patients the bad news that there's no point in doing a MicroTESE. But for 98 or whatever % of men that come into my clinic, there is no test. There's no other findings that would preclude them from having a MicroTESE. Yes, some may be slightly higher, some may be slightly less chance, but there's no other tests that are looked at. And everyone's looked at different things. People have looked at the FSH. If it's high, is it good? Is it low? If it's good, LH. So all these different things, and they're all different studies that actually a lot of them are contradictory. But you do need a full workup. You do need to work out if you need any sort of sperm-friendly hormonal tests, and people do need genetic tests. But it's a lot of the time be very difficult to predict a particular patient's outcomes just from those.
That's okay.
That's why when a patient comes to me, I talk about overall all patients. Right. In your general scenario, this is what we're after exactly.
Yeah. And by the time you're sort of at the MicroTESE, this is your shot, isn't it? Like this is your chance to find sperm, and then you need to move forward potentially.
Correct. And look, John, that's a really good point. So, I mean, the MicroTESE success rate is varied. I mean, it's anywhere from I've been just looking at my data, 50, 60% or so in all patients coming in who don't have sperm.
Right.
And that means, let's be even conservative, let's call it 50%. That means, John, that 50% of men are having this operation and not getting the outcome that they want. 50%.
Right.
So the question is, you would think that 50% of men then would have regretted having the operation, all that type of stuff. And I can tell you with that, I don't recall any man coming back and telling me and saying, "Doc, I don't know why I did this. This was the worst thing I've ever done."
Yeah.
Okay.
Right.
What this does, anyone who's ended up on my operating table, it's been years in the making, John. It's been a long process. I mean, you're writing a book about it. It's been a long process.
That's right.
Okay.
Hopefully
it's been a long process. And what this does, and to use the book analogy, it allows them to close that chapter on their life. They know that they've had what's the best available treatment in the world. Okay. They've had it. And whatever the outcome is, the outcome is. Okay. So if they find sperm, brilliant. Okay. If they don't find sperm, they can put their head on the pillow at night and know that they've done everything. There's no regrets, and they can just move on to whatever that next step is in their lives. And that's a really important part of this. This is a psychological battle. You know that, John. People go through, and that's why all these IVF centers have really, really, really good, have really, really good counselors, right? Because they need it, right? People need that support, and half of the battle is really just being able to get on the have closure in something, and that's what a MicroTESE gives people. It's closure one way or the other.
Yeah. I know for us, Laura and I use the analogy, me being a rugby player, that we were going to leave everything out on the pitch, and that was going to be the first MicroTESE. But when we were able to do the second one, it came into action again, and we had to do more to leave it out on the pitch. Couple of extra questions here, Dr. Katz. What are the side effects of a long MicroTESE surgery?
The MicroTESE, although it takes 3 hours, 3-4 hours sometimes, is a very well tolerated procedure. Probably the biggest side effect that I get concerned about, and the most common side effect, is actually lowering a man's testosterone. Now, as I mentioned to you, they often go hand in hand. So quite a lot of men moving into the surgery, I know afterwards they're going to need testosterone anyway. Okay. But in a man who has normal testosterone, okay, a man who's got normal testosterone moving into the MicroTESE, there's a real risk, somewhere the rounds of 10, 15%, something like that, depends on a whole lot of factors, that they may need long-term, forever testosterone replacement after the operation. That means obviously most men don't, but that's a real risk. Now, testosterone replacement, as you know, John, is not the biggest thing in the world, but it is. That's probably the most common risk. Most of the other risks are rare, and I'm dealing generally with healthy, fit, otherwise fit young men, and so the risks are pretty small.
Yeah. Well, I know my recovery. Sorry, carry on.
No, carry on. You need to carry on, John.
Yeah, I know my recovery from your surgeries. Whilst I prepared like over the top, I didn't even really require much analgesia, and it was, like you said, a bit of some ice packs and supportive underwear and a bit of rest, and it was a little uncomfortable, but it wasn't debilitating at all. So yeah, if you're looking at it, you just know, it can be overcome relatively easy over a few days.
But I will say as well, John, and I'm always cautious, not only in my surgery, but what I tell patients is that, there are patients who are more sensitive down there, so to speak. Yes. And different pain thresholds for different people. So, although you had minimal painkillers and all that stuff, some patients do need painkillers, sometimes for up to a week. But everyone's a bit different.
Okay, cool. Well, I think one question just went past, vasectomy reversals. What are the success rates finding sperm after a reversal? So
this is the exact opposite of what we're talking about. This is for men who have they thought they had enough children, and the man underwent a vasectomy, and then whatever the reason is down the track, either they want to have another child, or he's got a new partner, or whatever the reason is, the patient decides to have what's called a reversal. Now, the reversal in itself is another very highly sort of technical procedure using very, very fine sutures that are much thinner than your hair. It takes actually longer than a MicroTESE. It takes 4 to 5 hours actually. And the success rates, it depends on how you define success rates. The success rates of success rate of a vasectomy reversal, the easiest thing that I keep track of is actually the sperm coming back into the ejaculation fluid, okay? Because that's an easy metric to have. When the patients get it, I've got it on my thing. And in my hands, with an average of about 7 years between vasectomy and reversal, there's about a 90% chance, 80 to 90 roughly % chance of patients having sperm come back. Now, that doesn't mean they're going to have a child, okay? Because to have a child, as everyone knows, it takes 2 to tango. There's so many factors that come into having a child. And in fact, 1/3 of couples going through the IVF process, there's no obvious problem, okay? The man's got perfect semen count. She's got no fertility issues, but for whatever reason, their sperm and egg don't mix. So that's why, although the success rate for vasectomy reversal is very high, and I do a lot, I probably do more or as much as any urologist in Australia, vasectomy reversal. I've got a high success rate for sperm coming back, but it's reduced the patient that actually conceive for all those various reasons that I mentioned. But of course, you know, some of those photos that you've got on the wall are from babies post septum reversal as well. So yeah.
Okay. Thank you very much. So just a quick question passing through here. It looks like someone's they found sperm by MicroTESE, though they're experiencing multiple miscarriages. His question is, or her question is, can azoospermia cause recurrent pregnancy loss? Can it be a factor?
Can azoospermia?
Yeah.
Look, I'll have to pass on that one. There's so many more clinical factors that come into that question.
Yeah, so hopefully we'll cover that with the people in the know down the line.
Yeah, correct.
Couple more questions. How best, in your eyes, can a partner support someone going through this procedure?
Look, John, as I so often say, it's two to tango. This is a couple's issue. Yeah. Just because one person's got a problem, it does cause, it's an issue. And people need support. In fact, we've just done a review article specifically looking at male, and just for your listeners, I only deal with males. Yes, I link up to all the various IVF specialist clinics around Melbourne, but I just focus purely on the male and the sperm. And we just did a look at review of the supports and sort of a male's experience going through the journey. And it's really, males suffer. They really suffer going through this. When a man's told he's infertile, it really hits him, you know, right where it hurts. Patients go through all constellation of symptoms, depression, it's sense of loss. It affects their manhood. It's a real a downer for lots and lots of men. And that support that you can get through, you know, the professional IVF services is just so important. And I tell my patients that going and getting support from a counsellor is a sign of strength, not a sign of weakness, because it's such a roller coaster that men go through, that all couples go through, the man and the female. You know, when the female's going through all hormonal changes with all the injections and the procedures as well, you know, it's a roller coaster of emotions. And so having that support is just so important. And unfortunately, in my experience, there seems to be so much focus on the female, when the male is just equally as affected as well. And so, you know, my shout out is to all those people who are going through this. Don't forget the male in the picture. They're also suffering a lot of the time.
Yeah, and it is hard to watch when you're diagnosed with male infertility and your partner. It doesn't look like they've got fertility issues, but the burden of treatment does lie with the female. So, just a few more questions. I think we've got a few minutes left. Does the success rate of finding sperm change much depending on which doctor or facility performing the procedure?
So, as there is with most procedures in surgery, there's two things. There's experience, and there's something called a learning curve. And in fact, in the paper that I have published with my team, looking at my particular learning curve the last 5 years, I've improved my outcomes. You know, it was probably around about 40% when I was starting out, and it has increased, you know, up until that, you know, 60-65% success rate for finding sperm. So even in my own personal experience, I know that you just get better. Now, that's not just me. Okay, and what do I mean by that? So this is a team effort. So it's the IVF specialists, and a real big shout out goes to the team in the IVF laboratory, those embryologists, those hardworking, really highly skilled embryologists that spend hours and hours and hours back in the lab, searching through all of the tissue that I've given them, trying to find that one little wriggler that they can inject into the egg. And so the success rate also comes from the IVF lab's learning curve as well, because the way I do a MicroTESE, the way that I've developed, the way that I learned in the United States from Professor Schlegel, really it's That's just how, that's the gold standard. And when I brought that back to Australia, I actually sent over one of the IVF labs head embryologist to America so they could learn how it's done, what sort of the world best standard is, so they can bring that skill back. So it's not just the surgical skill, it's the skill of the IVF lab. And yes, so when I link into the IVF groups, you know, you've got to make sure that you're linked into ones, and the ones here in Melbourne are very, very good. That they've got the experience, expertise of the lab as well behind you to do this. And not all labs can do it in Melbourne. A lot can, but not all labs have that expertise. So it is truly a joint team effort when there's a success.
Well, we're glad we found your team. And this is the last question we have here. If anyone has any questions, just throw them in the thread. And Laura should come in here and tell me how to turn this off once we're actually done. So should sperm checks be encouraged as a totally normal and standard health check for men?
So what I find in my clinic is that almost by default, when a couple comes in for infertility, you'll see that the woman has gone through the ringer. She's had all these tests, and then suddenly they think, well, maybe we'll check him. And lo and behold, there's the problem. So most patients don't appreciate this, but when I actually give a talk to anyone, patients, IVF doctors, whoever it is, I tell them that, in fact, in 50% of the time, there's a male factor going on, and up to 75. In 2/3 of the time, there's a male factor as a cause to a patient's infertility. And in 30%, it is the actual main cause. Often it can be a combination of both, but in at least 1/3 of men, it is the only cause of why this couple cannot conceive. And so my suggestion to everyone going out there is, if your partner's getting a test, you need a test as well. And it's as simple as doing some blood tests and a semen analysis. And if those are okay, you're pretty good to go. But if they're not, that needs to be looked at as to why that is so. So it's really, really important. In fact, all guidelines around the world, both in Europe, America, and I'm starting to develop some here in Australia, suggest that if a couple presents with infertility, both the male and the female need to be assessed at the same time. Don't just put the female through the ringer. That's unfair. The male needs to be looked at as well. Very important. Two to tango, as I keep saying.
Yeah. I think that's what we find. A lot of men think that, well, you go through life thinking that your sperm's going to work, and no one checks, and it's normally an afterthought. So, well, Dr. Katz, I think we've. Hang on, we've got another one here. Do you have some simple tips for preparing? Well, I think we might have gone through this earlier on. We've already answered this question, so we'll be putting this up and sharing it later on as well. So you'll be able to catch up with any questions that you missed out on. So, Dr. Katz, we really appreciate you taking the time. I know social media is not your buzz, but we really appreciate it. And if you want to know anything more about what Dr. Katz offers, then menshealthmelbourne.com.au. That'll give his extensive list of qualifications. And yeah, I believe I'm very grateful for our little Adeline at 6 months old. And yeah, thank you very much for coming on this evening.
Oh, look, John, thank you for having me. I know I put this off a long time. I don't like the spotlight and the whole social media stuff. And I mean, you convinced me to, you know, when I saw how many followers that you and Laura have, and I see, I mean, I'll give you one, I just thought about it just now. I saw a patient today who I did a telehealth with from interstate, and they were told basically there's no chance, less than 1% chance of them, you know, finding sperm. And in my hand, that gentleman's particular condition, there's about 70% chance of finding sperm. Okay. And this couple's gone through, since they were told at the beginning of the year that they can't basically ever become biological parents.
Yeah.
When I said those words to them, John, that there's a pretty good chance, you know, the response of the poor partner, I think with, you know, tears in her eyes, said, this is just the best news I've ever heard, like the whole year. You know, they've had this. So that's why these forums are so important for your patients, to know that they're often, not always, but often there's hope. And that's what I try to give patients, hope. And that's what really we try and do for all our patients.
I think that's what we do in the IVF community. It's hope. It's about all we have sometimes, and we just appreciate the specialists that have taken the time to help us and do their best for us. So, Dr. Katz, we will sign off. And like I said before, Laura needs to come in here and help me turn this live off. But I want to say thank you very much. Thank you to all those who joined us this evening. And yeah, we'll come up with another one of our array of people that helped us next month. So thank you very much, Dr. Katz. Have a great evening, and yeah, we appreciate you. Thank you.
Thanks, John. Take care.
Thank you.
Bye-bye.
Well, that's Dr. Katz, guys. Thank you very much for coming on board, and Laura finally heard. So
it's not that hard.
Yeah. So thanks very much, guys, for joining me, and yeah, we'll find another one of the specialists or the people that helped us on our journey next month. So take care, have a great evening, and yeah, thanks for coming on board. See ya.